Thank you, Peter. So I don't have any disclosures except the fact that I did have an anesthetic when I was 2 years old. So, so we'll take 3 other topics and then we'll bounce back to Peter again in the interest of time. So commonly, regional anesthesia has become relatively common in the adult population, and it's gaining a lot of interest in pediatrics. So the question is regional anesthesia safe in children? And if you want to use your buttons, all right, so I guess I don't have to even address this issue. Let's move on and see what data we have on regional anesthesia. So the 2 main questions that you might have, particularly if you're working in an adult institution, is can regional anesthesia be performed in children who are under general anesthesia, and does lipid work for rescue in regional anesthesia in children? So this is a tricky thing. So one of the problems that we had with the pediatric anesthesia population is that we couldn't go and talk to our parents and give meaningful data. You know, for the most part, those of us who've been practicing pediatric anesthesia for over 2 decades now, you just walk to the family and tell them, you know, we've done this before, we've never had a problem with this, so how often do you go and tell a patient who's getting a caudal block that, you know, there's a likelihood that they could actually inject into a nerve root, there's a likelihood that you could have a cardiac arrest and you could die. Issues that we don't know because there's really no data available. So about in 2007, this group here, we got together at a meeting at the Society for Pediatric Anesthesia, and we formed this little consortium called the Pediatric Regional Anesthesia Network. And this was the first manuscript that was published from this group. We now have over 70,000 blocks, and we have data on over 70,000 blocks. And I'll give you some of the information that we have from this consortium. So this was the burning question that was asked, and this again is before we had some of this data. And this was a task force that was put together by the American Society of Regional Anesthesia. The question was, could regional anesthesia be used safely in someone who's asleep? So the whole issue came up from a case report that was published in Regional Anesthesia Pain Medicine, pulled out of the closed claims database. So there was a 60-plus-year-old lady who goes in for an abdominal surgery. She wants to get a thoracic epidural, but refuses to have this under sitting awake, and she wants to be asleep. So the first attempt is made by the resident. There's a second attempt that's made by a resident. A third attempt is made by the attending who's in the room, and then they call the other unfortunate guy who was standing in the hallway, and he's the 4th attempt, and they managed to get an epidural anesthetic. The case goes hunky-dory, no problems at all, except she's paraplegic post-operatively. And they found that the needle was in the, directly in the spinal cord and caused injury. So this became a big furor, and then they reached out to pediatric anesthesiologists and said, geez, you know, this is a real problem, because if we now publicize the fact that regional anesthesia should not be done in people who are asleep, we would be out of the business altogether. So we got together as a group, about 20 of us from around the world, and we came up with an editorial, but nevertheless there wasn't enough data at that point to support anything. So this task force was put together by ASRA with Admir Hadsig. Joe Neal was the editor-in-chief of Regional Anesthesia Pain Medicine, and unfortunately Chris Bernard is not with us anymore, but he put a lot of work into this. if I can move this forward. So we came up with a bunch of recommendations, and if I can move this forward. So what we felt was a moving target was a bigger problem than having a patient who's still. So that was one of the recommendations. The second recommendation that we made, which I think was very confusing to the constituents, was the fact that you shouldn't do an interscalene block under general anesthesia. And if you look at the literature, so there's class 1 evidence to show that if you did an interscalene block in someone who's asleep, there's a likelihood that you could actually inject in the intrathecal space and you could have a syringe. And we did mention that recommendations will change with changing technology. So this is a publication from 2008, and this was the then prevailing mood. So fast forward, the Pediatric Regional Anesthesia Network, and now we've got prospective data collected on over 50,000 cases, and this is data from the PRAN database. If I can move this forward. So what we did is now we collect prospectively data on children who are asleep, who are awake, and then we also look at the utilization of a neuromuscular blockade versus not using a neuromuscular blockade. And if you look in this cohort, and again, this is a manuscript that will be published in Regional Anesthesia Pain Medicine. It's going to appear in the August edition of RAPM. And what we found was again, what we found was the number of complications actually in a patient who's asleep without neuromuscular blockade was far less than even in awake patients. So our recommendation, at least from the PRAN database, is to utilize, for us to perform regional anesthesia with patients who are asleep. The other question then is, what about the risk of local anesthetic toxicity? So if you were to look in Guy Weinberg's website, he's got a website that's www.lipidrescue.org. And if you look at the data, there is plenty of data there, at least on children who've been resuscitated with the use of lipid. So here you go. This is from our PRAN database. We now have about 70,000. Oh, I wish this would move faster. But the most common block that we do is a supraclavicular block for upper extremity blocks. I'm going to just ask you to advance the slide, sir, if you don't mind. The most common lower extremity block is a femoral nerve block. And now you see with the use of ultrasonography, thank you. Thank you very much. With the use of ultrasonography now, we're doing a variety of different blocks, which include the ilioinguinal blocks, TAP blocks, etc. And you can see that catheter utilization is much higher. We have a fair amount, over 12,000 catheters that we've used in pediatric populations. So this is about 22 hospitals in North America at the current time. I'll skip this in the interest of time, and you can see that you can perform a block very comfortably. This is a little 3-month-old baby who's having a cleft lip repair done with very little risk if you do it right. And this is a little baby getting a TAP block done. We've also looked at the pharmacokinetics of local anesthetics in these patients, and you can see very well that it is much lower than the allowable toxic level. So toxic level of bupivacaine is about 2,100 nanograms, and you can see we're at about 200 nanograms with the use of local anesthetic in this population. So the question is regional anesthesia safe in children? Oh, geez. Not a single convert. Okay. That's too bad. I think it's the music. So here's another burning question, right? So we all take care of these little babies, and occasionally I know that we all use cricoid pressure for, to prevent aspiration. Is cricoid pressure necessary for rapid sequence induction? And let's take just infants. Is cricoid pressure necessary in infants? All right. All right, let's go and look at the data that is out there in the literature. So Selleck in 1961 introduces cricoid pressure. So what he did was he inflated the abdomen with a balloon, used up to about 20 millimeters mercury, went up to about 60 millimeters mercury, and what he did then was to use something to compress the C-spine. So he looked at about C5, and he used a little pressure to compress against the cervical spine. And then he gently put the head up at a slight tilt, and then looked to see how much of the contents of the stomach he was able to aspirate. So one of the things that, if you look at Selleck's original paper, he talks about actually having to suction the stomach prior to and suction the stomach after. And this is his recommendation, was to use cricoid pressure, but suction the stomach after, suction the stomach later. So this was 1961. And it became common practice. Everybody has been using cricoid pressure. So there's really no studies to prove its efficacy. In fact, if you look at some of the studies where they've used cricoid pressure, and then they've later looked at gastric contents, there's aspiration, especially in the OB literature. There is a fair amount of aspiration that has been recorded despite the use of cricoid pressure. And this is a very interesting editorial by Jerry Lerman, and it's titled "Cricoid Pressure, May the Force Be With You." And it's, so I'm just going to read this quotation because it's kind of very interesting. Currently, there is insufficient evidence to advocate or abandon the use of cricoid pressure to prevent passive regurgitation in at-risk anesthetized patients. We need to prove that properly applied cricoid pressure is effective at preventing regurgitation or discarded. It is time we take stock of what we do and do it better. We owe it to our patients. So this was fairly a compelling argument based on an article that was published. So let's fast forward. So this is the normal cricoid pressure that we apply. Again, C5, C6, we all apply. And again, who knows how much pressure to apply? You know, Peter's hand may be bigger than mine, and so if he were to push a little harder versus someone who's pushing a little less, we don't have a recognized force that we use in children particularly. So there are some controversies to the use of cricoid pressure, right? So if you have a little infant, it can actually impede mask ventilation in smaller patients. So in a patient who's in trauma, for example, it can actually cause posterior displacement of the cervical spine. And there is also questionable efficacy. The most compelling argument is that sometimes it becomes very difficult to ventilate these patients. So this was published in Pediatric Emergency Medicine, and you can see that the alignment of the cricoid and the esophagus. So what happens is there is a lateral shift of the esophagus. You don't normally almost compress the esophagus, but you could actually shift it laterally. So you can still continue to aspirate despite the fact that you use cricoid pressure. And this was a review article that was published this year in Anesthesia Analgesia by Rami Salem and company. And here you can look at, so this was a bunch of kids who were having gastrostomy tube placement. And what they did was they looked at the risk of aspiration. So essentially, they had contrast that was placed in the abdomen, and they actually did X-ray imaging to see if cricoid pressure actually prevented regurgitation. And so they also looked at the positioning of the head, and you can see that the adult is positioned at a much higher level, about 19 centimeters, as opposed to kids who are at about 7 centimeters. And they found that, one, the resting intragastric pressure is generally higher. Remember, it's a balloon. You've got a smaller balloon, you've got larger pressure in the abdomen in children. And because you have a shorter esophagus, you also have higher pressures in little children. So this was an editorial written by Martin Yor from Switzerland, and he looked at the reason why we really need to do cricoid pressure. So he stratified a variety of different patients based on their age, and he said that, is it necessary to do cricoid pressure, or do we need to do rapid sequence induction in these patients? And if you look at the triangle, the bottom of the triangle is narrow, so is it really necessary for pyloric stenosis? Probably not, because you can empty the stomach out. An appendectomy or a non-reducible hernia, maybe. But if you had massive intestinal distension, or you had bleeding after tonsillectomy, or immediately following a meal, he suggests that you use cricoid pressure and do a rapid sequence induction. So, is cricoid pressure necessary for rapid sequence induction in infants? I get the cool music too. All right, we've got a few converts. All right. So here's another burning question, right, that we have in the pediatric world. Is atropine pre-medication needed in infants? So let's move on and see what you guys feel. All right. So 77% of you feel that it's not necessary. So let me get a show of hands. How many of you in the audience have used Halothane? All right. So there's just a few of us gray-haired folks who have used Halothane. So used to be a very important part of Halothane anesthesia, I recall, when I was a resident and when I was a fellow in pediatric anesthesia. And our biggest concern was that, yes, it was a myocardial depression, depressant, and you used to have these patients brady as soon as you did laryngoscopy. So there's a couple things that happen with laryngoscopy. One is you do have a sympathetic and a parasympathetic response, although the parasympathetic response is greater. So you have a larger vagal tone in these patients, and you have to remember to offset bradycardia due to volatile agents. And again, safety has now changed with avoiding Halothane. So most of the work that has been done in infants particularly has been done in the intensive care units, where if you look at your neonatal intensive care unit and pediatric intensive care units, they do a fair amount of intubations in these patients. And they've always tried to see what is best practice for these patients. So the physiological changes are multiple. One is the vagal response. As we said, it's going to cause bradycardia. There's an increase in intracranial pressure. There is potentially systemic and pulmonary hypertension. and there's hypoxia. So these are things that happen with any laryngoscopy. So is it necessary? And this was an editorial that was written by Sunny Anand, and mostly they were looking at the need for sedation for patients who are undergoing tracheal intubation. And there's too much data here, but nevertheless, just to give you a summary, they look to see what happens, in terms of hypertension, pulmonary hypertension, hypoxia, etc. But the main thing, let's focus in on the bradycardia and the need for the use of atropine. So this is in Pediatric Child Health. This is the position paper of the Canadian Society of Pediatric Anesthesia Society, and this was published in March of 2011. And if you look at this, there's a randomized control trial using atropine. These are in newborn infants who require tracheal intubation, and they looked at atropine versus non-use of atropine, and they clearly showed that there was a prevention of bradycardia compared with no therapy. When they looked at glycopyrrolate, again, should you use glycopyrrolate versus atropine, there was actually, this is interesting because they gave it to both groups, and of course they did not find any bradycardia. So what is our current recommendation in our own institution? We in our own institution do not routinely use atropine for all children or infants who we anesthetize prior to laryngoscopy. So, is atropine pre-medication needed in infants? All right. Well, thank you very much. As I said, we have a few more that we can run through. I think if you want to, we could, but unfortunately, a lot of you have to be at a variety of different places. Thank you very much. We wanted to make this an evidence-based approach to all of the questions that we had. Unfortunately, 10 different things was a lot that we could achieve in this short hour. I want to thank Peter Davis for his time and his wonderful contribution. Thank you all very much.